Yeah, I can go with your
Okay,
presentation, doctor, and wish you all the best.
okay. Thank you very much for taking time at your busy schedules. Today you joined us on the webinar of Neurology and Therapeutics 2021. My presentation will be about how ultrasound can help in diagnosis of the thoracic outlet syndrome. I hope it will be interesting to you. As you know, the thoracic outlet syndrome refers to the compression of the neurovascular bundle by various structures in the area just above the first rib and behind the clavicular leading to a wide range of signs and symptoms. The thoracic outlet syndrome is due to dynamic compression of the brachial plexus with or without subclavian artery or vein at the thoracic outlet, at the interscalene triangle, at the costoclavicular space, and the pectoral minor space. As you can see, the scalene triangle is created from the base, is from the first rib, the middle and arterial scalene muscles. The costoclavicular space is formed between the clavicle and the first rib. The pectoral minor space lies between the insertion of the pectoralis minor tendon and the ribs of the chest wall. In our research, we took 338 Caucasian patients with symptoms such as pain, which was in the neck, in the upper back, supraclavicular region, shoulder, and have been present at least for 12 weeks. Numbness, paresthesia, and or weakness, all in the arm, hand, or digits. All patients underwent clinical MRI, CT, radiographic examination, electrophysiologic, and ultrasound assessments. We excluded 227 persons who had trauma of soft tissues, motor neuron disease, radiation damage of the brachial plexus, radiculopathy, cervical myelopathy, compression neuropathies, suspicion of disease, and hereditary neuropathies. We've included 111 persons with positive provocative tests, ultrasound signs that show the compression on one or more levels of the brachial plexus. 24 persons were also recruited with formed the control group. A control group was also examined to obtain normal values of cross-section area of the lower trunk and to check for the occurrence of any abnormality. None of subjects had subjective or objective symptoms and signs suggestive of TOS. The examination includes assessment of static images and dynamic effect of selected provocative maneuvers. We used stress tests to find the compression in the interscalene triangle. Patient's arms were placed in abducted position, elbow in 90 degrees of flexion. Measurements for each limb were were obtained with the head turned to the contralateral arm. Test was positive when the branches changed their relative position. For the compression in costoclavicular space, we looked for the wedge sickle sign, which is indication of causing indentation of the lower trunk of the brachial plexus. For the compression in the pectoralis minor space, the patient is placed with the head turned away from the side of the scan. The ipsilateral arm was abducted to 90 degrees and elbow was fixed. In the infraclavicular region, the deformation of the axillary artery can be assessed as a compression because of the close approximation to the cords. We divided our patients with the compression at different levels in three groups. The first group was when compression was in interscalene triangle and it was for 65.7%. Second group was when compression was in costoclavicular space and percentage was 21.6. Third group was when compression was in retropectoralis minor space and it was for 12.6%. As for the causes of compression, we found that at the level of the interscalene triangle there was compression of the brachial plexus between the anterior and middle scalene muscles, enlarged lymph nodes, synovial kyst, arteria dorsalis scapulae, additional scalene muscle, scapulohyoid muscle, brachial plexus trunk tumor, and enlarged transverse processes. So the most frequent compression was due to the squeezing the brachial plexus between the anterior and middle scalene muscles and due to the enlarged transverse process of seventh vertebra. At the level of the costoclavicular space, we had compression of brachial plexus between the first rib and the edge of the scalene muscle. Subclavian artery aneurysm, Pankos tumor, mesothelioma, supraclavicular metastasis. At the pectoral minor space, the compression was by the edge of the pectoral minor muscle and lymph nodes, and the enlarged lymph nodes. For an example, Dejerin-Klumpke palsy, you can see the compression of the lower trunk by the tumor and atrophy in the tenor muscles. As for atrophy, muscles much more suffered when the compression was in the costoclavicular space. Perhaps this is due to the proximity of the nerves to the bone elements, and less when the compression was at pectoralis minor space. As you can see, only one case was detected when the deltoids muscles was involved. We noticed that the cross-section area of the spinal nerves was enlarged only in second group, who had the compression of the lower trunk in costoclavicular space. In the first and the third groups, there were no differences. Comparing the measurements of cross-section area with atrophy, we found that if there is no atrophy, there will be no differences in the cross-section area, and it was for 55.8%. Atrophy are usually accompanied by enlargement of cross-section area, but stress test might be as positive as negative. So we don't find the correlation in the enlargement of the cross-section area and the frequency of the atrophy. Our findings are that the stress tests are good when the compression is in interscalene space. The measurements of cross-section area is informative when the compression is at the costoclavicular space. The provocative maneuvers for the pectoralis minor space are good. Also, you can find tumors, cysts, or other pathology in supraclavicular region. CT and EMG can be used as additional method to include other pathology. In conclusion, I can say that the advantage of ultrasound is that it is quick. Many parts of the brachial plexus as well as surrounding soft tissues can be assessed with high spatial resolution. Also, we can do dynamic examination due to the research. Due to this, we can tell on which level the compression is. The compression of brachial plexus more frequently occurs in the interscalene space, and it was for 65.7%. The atrophy in the arm frequently in the hypotonia are usually related to the compression in the costoclavicular space, and it was for 70.8%. The evaluation of cross-section area is specific for the compression at the costoclavicular space. Thank you for your interest and your attention.